Hello students, today we are going to revise the topic schizophrenia, which is a psychotic disorder. So let's go through the history of schizophrenia and start the topic. So in the history, Imre Kaplan, an eminent psychiatrist, in 1896 formed the concept of dementia paradox, mental deterioration. In 1911, Eugen Bleuler coined the term schizophrenia. Means schizo means split and phrens means mind. Kurt Schleicher described 11 symptoms collectively called first-rank symptoms (FRS), whose present absence of cause of brain disease was diagnostic of schizophrenia. Now we are going to see the definition. So the schizophrenic disorders are characterized in general by fundamental and characteristics distortion of thinking and perception, and by inappropriate or blunt affect. The most intimate thoughts, feelings and acts are often felt to be known or shared by others, and explanatory delusions may develop to the effect that natural or supernatural forces are to work to influence that affiliated individuals' thoughts and actions in ways that are often bizarre. So this was the definition of schizophrenia. Now we are going to learn about whether schizophrenia is psychotic or neurotic. So schizophrenia is a psychotic condition, as I told you earlier, characterized by disturbance in thinking, emotions, volition and faculties in the presence of clear consciousness, which usually leads to social withdrawal. So this is one definition of schizophrenia, that it is a psychotic condition and characterized by disturbance in thinking, emotions, volition and faculty in the presence of clear consciousness, which usually leads to social withdrawal. Now let's see the classification according to DSM-4 classification, and at least 2 or more of characteristic symptoms must be present for the particular portion or part of time during 1 month of period. It means in 1 month of period, but at least 2 or more characteristics of symptoms must be present in person. First one is delusions, hallucination, disorganized speech, grossly disorganized and catatonia behavior, negative symptoms such as flat affect, alogia and avoidation. So what is and according to ICD-10 classification, it comes under F20 to F29, schizophrenia, schizotypal and delusional disorder, F20 schizophrenia, F20.0 paranoid schizophrenia, F20.1 hebephrenic schizophrenia, F20.2 catatonic schizophrenia, F20.3 undifferentiated, F20.4 post-schizophrenic depression, F20.5 residual schizophrenia, F20.6 simple schizophrenia, and F21 is a schizotypal schizophrenia. So this was the ICD-10 classification. Now we are going to learn about epidemiology. It is the most common of all psychiatric disorders and it's prevalent in all culture across the world. So 15% of new admissions in mental hospitals are schizophrenic patients. Schizophrenic patients occupy 50% of all mental hospitals bed and about 3 to 4% per thousand population in every community suffer from the schizophrenia. So this was about the epidemiology. About 1% of general population have the risk of developing this disease in their lifetime. Men, and it is equally prevalent in men and women. About 2/3 of cases are in age of 15 to 30 years of age group and very common in lower socio-economic groups. In men, its peak age of onset are 15 to 25 years and in women it is in 25 to 35 years. Etiology, what are the causes, what are the etiological factors? First one is biological theory. In that biochemical theory, what it suggests is that dopamine hypothesis. Whenever patient is suffering from schizophrenia, in the brain dopamine level is increased. So excess of dopamine dependent neuronal activities in the brain may cause schizophrenia. It means dopamine level is increased. Other biochemical hypothesis, abnormalities in the neurotransmitters. There will be some abnormalities in neurotransmitters. Non-epinephrine, serotonin, acetylcholine, gamma aminobutyric acid. In this neurotransmitter, there will be some abnormalities and abnormalities in the neuroregulators, prostaglandin and endorphins. Neurostructure theory, we have seen biological theory. In that biochemical theory we have seen. Now we are going to learn about neurostructural theory. So in neurostructural theory, what happens is prefrontal cortex and limbic cortex may never fully develop in the brain of person with schizophrenia. It means the person who is suffering from schizophrenia, their prefrontal cortex and limbic cortex is not fully developed. In CT scan and MRI, study of brain structure shows, whenever you go for CT scan or MRI, the structure shows in the brain. Decreased brain volume will be there, lower lateral and third ventricles, atrophy in the frontal lobe, cerebrum and limbic structure, and increased size of sulci on the surface of the brain. Next we are going to learn about genetic theories, how the genetics affects to schizophrenia. More common among people born of consanguineous marriage, identical twins affected 50%, fragmental twins affected 15%, brother and sister affected 10%, one parent affected 15%, both parents affected 35%, and second degree relatives affected 2 to 3%, general population affected about 1%. So this was about the genetic theories. Next we are going to learn is prenatal risk factors. What are the factors that affect the pregnancy? Maternal influenza, birth during late winter and early spring, complications of pregnancy, particularly during labor and delivery. Next, we are going to learn about psychodynamic theories, developmental theories. According to Freud, in psychosexual development, oral stage regression present along with that denial, projection and reaction to formation. The individual have poor ego boundaries, fragile ego, inadequate ego development, superego dominance, regressed id, ego, love-hate relationships, and arrested psychosexual development. In family theories, mother and child relationship, the mother of schizophrenic as cold, over protective and dominating thirst, retarding the ego development of the child. And dysfunctional family system, in this, hostility between parents can lead to schizophrenic daughter and double-blind communication. Parents convey two or more conflicting and incompatible messages at the same time. Next, we are going to learn about stress vulnerability model. In that, biological stress that leads to biological vulnerability and coping skills simultaneously, and that leads to symptoms of schizophrenia. Social factor more prevalent in area of high social morbidity and disorganized, especially among members of every low socio-economic classes. Stressful life event also can participate the disease in predisposed individuals. Psychopathology. So in psychopathology, genetic predisposition plus environmental, social and psychological factors both leads to neurodevelopmental abnormalities and target features that leads to brain dysfunctions and proper balance of chemicals, and that dysfunction of brain chemical or dysfunction of brain, or there is abnormality in neurotransmitter that leads to schizophrenia. Now, schizophrenia has multiple psychopathological dimensions, so we are going to see one by one. In positive symptoms, delusion, hallucinations and thought disorders will be there. Negative symptoms, apathy, social withdrawal, restricted affect and anhedonia will be there. What is anhedonia? Anhedonia is inability to experience pleasure in any activity. That is anhedonia. Cognitive skills, attention, memory, executive function, and mood symptoms, dysphoria and depression will be there. And in other, agitation and excitement will be there. Next is phases of schizophrenia. Prodromal, psychotic and residual, and that prodromal decline in functioning that precedes one first psychotic episode, socially withdrawal, irritable and physical complaints, newfound interest in religion and other occult. In psychotic, positive symptoms will be there, which is also called an acute phase. Perceptual disturbances, example, auditory hallucinations might be there. Delusions, usually secondary delusions or reference is common. And disordered thought process and content. In residual, which is chronic schizophrenia, in that occurs between episode of psychosis marked by negative symptoms, flat affect, social withdrawal, and odd thinking and behavior will be there. So these are the phase of schizophrenia: prodromal, psychotic, and residual. Clinical features: there are 4 A's of schizophrenia: affect, autism, loosening of association, and ambivalence. Positive symptoms is hallucination, delusions, formal thought of disorders, odd or bizarre behaviors. In negative symptoms, flat affect, alogia, anhedonia, violation, inattention, and self-care deficit. Now, what is first strength symptoms? So, first strength symptoms is audible thoughts, voices, arguing, voices commanding on first action, thought withdrawal, thought insertion, thought broadcasting made, feelings made, impulses made, volitions act, delusional perceptions, and somatic passivity. These are the first strength symptoms in schizophrenia. Thoughts and speech disorder, in that autistic thinking, loosening of association, thought blocking, neologism, poverty of speech, poverty of ideation, echolalia, preservation and verberation will be there. Verberation is senseless repetition of words or phrases. Delusion, persecution, grandeur, reference, control, infidelity, somatic delusions, and desire. Over inclusions is irrelevant items in speech, impaired abstractions, concreteness, and ambivalence. So these are the thoughts and speech disorder symptoms which is present in schizophrenia. Disorder of perception. What is a disorder of perception? Is hallucination. What a person perceives, whether it is audible, auditory, visual, tactile, gustatory, or olfactory. Disorder of affect is apathy, emotional blunting, emotional shallowness, anhedonia, inappropriate emotional response. And disorder of mood, motor behavior, increased or decrease in psychomotor activity, mannerisms, stereotypes, decreased self-care, and poor grooming will be there. And other features is decreased in work function, decreased in social relationship, decreased in self-care, decreased inability to concentrate, tension, insomnia, withdrawal or cognitive deficit, and loss of ego boundaries. Then there are few more symptoms: loss of insight, poor judgment, suicide, usually no disturbance of consciousness, orientation, attention, memory, and intelligence. No underlying organic causes will be there. In suicide, presence of association, depression, command hallucination, impulsive behavior, or return to insight that cause the patient to comprehend to devastating nature of the illness and take his life. Now we are going to learn about clinical symptoms of schizophrenia. What are the clinical symptoms present? Catatonia, catatonic, residual, paranoid, disorganized, and undifferentiated. In that paranoid schizophrenia, first we are going to learn. Paranoid schizophrenia, or paranoid means delusional. Paranoid schizophrenia is at present the most common form of schizophrenia, and it is characterized by following features: delusion of persecution, in that conspired people think that we are conspired against them, cheated, spied upon, followed or poisoned, then drugged. We are harassing them, we are obstructed in the pursuit of long-term goals. So people think that we are persecuting them. Next one is delusions of jealousy. The person's sexual partner is unfaithful. People think that. Delusion of grandiosity. Irrational ideas regarding their own worth, talent, knowledge, or power. May believe that they have special relationship with famous person. Assumption of the identity of great religious leader. That is delusion of grandiosity. And delusion of auditory hallucination. Threaten or command the patient hallucinatory voices such as whistling, humming, or laughing. And other features which present in schizophrenia is disturbance of affect, blunt, volition, speech, and motor behavior. It has good prognosis if treated early, and person deterioration is minimal. Patients are productive and can lead to a normal life. So this was about paranoid. Now we are going to learn about hyperpanic schizophrenia, which is also called disorganized schizophrenia. It has an early and insidious onset and is often associated with poor premorbid personality. The essential features include thought disorders, incoherence, severe loosening of association, extreme social Impairment, delusions, and hallucinations are fragmentary and changeable. Other odd behavior that includes senseless giggling, mirror gazing, grimacing, mannerism, and so on. The course of chronic and progressively downhill without significant remissions. Recovery classically never occur. One of the worst prognosis among all the subtypes. So it means hebephrenic schizophrenia has not a good prognosis. Catatonic schizophrenia. Cata means disturbed. It is characterized by marked disturbance of motor behavior. Catatonic stupor, catatonic excitement, catatonic alternating between excitement and stupor. Clinical features of excited catatonia: increased psychomotor activity, restlessness, agitation, excitement, aggressiveness to all time, violent behavior, increased speech production, loosening of association will be there, frank endurance, excitement becomes very severe and is accompanied by rigidity, brexia, and dehydration can result in death. Then it is also known as acute lethal catatonia or pernicious catatonia. Clinical features of retarded catatonia: catatonia stupor, mutism, rigidity, maintenance of rigid posture against effort, negativism, posturing, voluntary assumption of an inappropriate and often bizarre posture for long periods of time, and stupor. Echolalia will be there, echopraxia, flexibility, part of body can be placed in position for a long period of time, even if very uncomfortable. Ambitendency, a conflict to do or not to do, and automatic obedience, obey every command irrespectively. So these are some few postures for catatonic stupor. Residual schizophrenia symptoms include emotional blunting, eccentric behavior, illogical thinking, social withdrawal, loosening of association. This category should be used when there has been at least one episode of schizophrenia in the past, but without prominent psychotic symptoms at present. Undifferentiated schizophrenia, and this category is diagnosed either when the features of no subtype are fully present or feature of more than one subtype are exhibited. Simple schizophrenia, early and insidious onset, progressive courses, and presence of characteristic negative symptoms, both hypochondriacal features, wandering tendency, self-absorbed idealness, aimless activity. It differs from residual schizophrenia in that there never has been an episode with all the typical psychotic symptoms. And prognosis is very poor in this. Post-schizophrenic depression. Depressive features develop in the presence of residual or active features of schizophrenia and are associated with an increased risk of suicide. Course and prognosis. The classic course is onset of exhibitions and remissions. It is described as the most crippling and devastating of all illness. Several studies have found that over 5 to 10 years period after first psychiatric hospitalization for schizophrenia, only about 10 to 20% of patients as having good outcome. More than 50% of patients have poor outcome with repeated hospitalization. These are the good prognostic factor and poor prognostic factor. Differences are there: abrupt or acute onset in good prognostic factor, and in poor prognostic factor, insidious and onset and later onset, younger onset, presence of precipitating factor, absence of precipitating factor. Good premorbid personality will be there, poor premorbid personality and poor prognostic factor. Short duration, less than 6 months. Long duration, more than 2 years. Predominance of positive symptoms, predominance of negative symptoms, family history and mood disorder, family history of schizophrenia. Good social support, poor social support, female sex, male sex, married, single, divorce and without. Outpatient treatment will be possible for good prognostic factor, and when a poor prognostic factor, and that institutionalization, it means hospitalization is needed. So what are the diagnostic evaluation available for schizophrenia? Is history collection, physical examination, neurological examination, mental status examination and blood investigation that includes vitamin deficiency, uremia, thyrotoxicosis, electrolyte imbalance and urine leukocytosis. CT scan and MRI that shows enlarged ventricles, enlargement of sulci on the cerebral surface and atrophy of the cerebrum. Now what are the treatment available? So first we are going to see pharmacological treatment. Conventional and antipsychotics, chlorpromazine, which we can give 300 to 1500 mg per day, Yoke 50 to 100 mg per day IM. Fluphenazine, Ticanate 25 to 50 mg IM, and every day, every 1 to 3 weeks we can give haloperidol 5 to 100 mg per day, 5 to 20 mg per day, and fluoperazine 50 to 60 mg per day and 1 to 5 mg per day. Then other commonly used atypical antipsychotics are clozapine, risperidone, olanzapine, quetiapine, ziprasidone, antidepressants, imipramine, clomipramine, sertraline and fluoxetine. Mood stabilizer is lithium, carbamazepine and sodium valproate we can use, and anxiolytics, diazepam and lorazepam. Electroconvulsive therapy is beneficial in schizophrenia. So the indications are catatonic stupor and controlled catatonic excitement. Severe side effects with drugs, schizophrenia refractory to all other forms of treatment, and usually 8 to 12 ECT are needed. What are the psychological therapies we can use? So psychotherapy, group therapy, behavior therapy, social skill training, cognitive therapy and family therapy we can use. Psychosocial rehabilitation, activity therapy to develop habit, training in a new vocation or retaining in a previous skill, vocational guidance, independent job placement. And what are the nursing interventions? Observe behavior pattern, posturing, appearance, psychomotor disturbances, hygiene, then identify the type of disturbances the patient is experiencing, then ask the patient about feelings while thought alterations are evident, note that effect and emotional tone of the patient and whether they are appropriate in relation to the thought or present situation, assess the speech pattern associated with the delusions, then assess the theme and content of delusional thinking. If the delusion is persecution oriented, assess the nature of the threat and risk for violence, assess the ability to perform self-care activities, sleep pattern and interaction with other patients. Determine any suicidal intent or recent attempts that have been made. now this was about the nursing interventions, what we can do or what we can plan. Now what are the nursing diagnoses? So disturbed thought process related to inability to trust, panicky anxiety, possible hereditary or biochemical factor, evidenced by delusional thinking, extreme suspiciousness of the others. Next one is ineffective health maintenance related to inability to trust, extreme suspiciousness, evident by poor diet intake, inadequate food and fluid intake, difficulty in falling asleep. Self-care deficit related to withdrawal, regression, panic, anxiety, cognitive impairment, inability to trust, evidenced by difficulty in carrying out tasks associated with hygienic dressing, grooming, eating, sleeping and toileting. Then potential for violence, self-directed or to others, related to command hallucination, evidenced by physical violence, restrictions of objects in the environment or self-destructive behavior. Risk for self-implicated or life-threatening injury related to command hallucination, evidenced by suicidal ideas, plan or attempt. Disturbed sensory perception, auditory, visual, related to panic, anxiety, possible hereditary and biochemical factor, evidenced by inappropriate response, disordered thought sequencing, poor concentration, disorientation and withdrawal behavior. Another one is social isolation will be there, impaired verbal communication will be there, and ineffective family coping will be there. So in social isolation related to inability to trust, panic, anxiety, delusional thinking, evidenced by withdrawal, sad, dull, affect, preoccupation with own thoughts, aloneness imposed by others, and impaired verbal communication related to panic, anxiety disorder, unrealistic thinking, evidenced by loosening of association, echolalia, verbalization that reflects concrete thinking and poor eye contact, and ineffective family coping related to highly ambivalent family relationships, impaired communication, evidenced by neglectful care of the patient, extreme denial and prolonged over concern regarding his illness. So today we have learned about schizophrenia, its history, definition, then we have seen the classification according to DSM-4 and ICD-10, then we have seen the epidemiology, etiology, clinical features, psychopathology, then we have seen the schizophrenia and psychopathological dimensions and phases of schizophrenia, clinical features we have seen, then we have seen the diagnostic measures and clinical symptoms we have seen, then we have seen the treatment of schizophrenia, we have seen the pharmacological treatment, then we have seen the ECT, electroconvulsive therapy, and psychological therapies we have seen in treatment, rehabilitation, nursing interventions, and nursing diagnosis we have seen in this video. This video was for BSc third year students. A revision class for schizophrenia. Thank you.